So today's course is on breakthrough in the retinal barrier, entering the subretinal space and the suprachoroidal space. And it's my honor to first, without much ado, to invite Sangeet. You are the first one, you know that, to come and delivering a talk on prophylactic chorioretinectomy. Now let me tell you, for the benefit of the fantastic audience, that prophylactic chorioretinectomy was first mooted by Ferenc Kuhn, and the great surgeon, and who has huge work in trauma. And today it's befitting that Sangeet speaks on this topic, because besides Ferenc Kuhn himself, Dr. Sengül Özdek, my good friend from Turkey, and Sangeet are the very few surgeons in the world who practice this technique to perfection. Over to Sangeet.
Thank you, sir, for the kind introduction. And I pay a tribute to Dr. Ferenc Kuhn, from whom I have learned this technique basically. So my topic for today is introduction to chorioretinectomies. So chorioretinectomies could be therapeutic, which were first described by the great Dr. Zivozinovic in 1987. And as a prophylactic procedure, it was described by Dr. Ferenc Kuhn in 2004. It is used in deep impact ocular trauma with the disincarceration or choroid penetration, and it reduces the RPE proliferation, fibrous ingrowth, and PBR from the wound site post-operatively. It could be performed, as I said, prophylactically or therapeutically. The method is the triamcinolone assisted vitrectomy is done with or without base shaving. Then deep, which is 100% endodiathermy, is done around the incarceration site. Then we remove the incarcerated retinal tissue with underlying choroid to the level of bare sclera. And 1 to 2 rows of prophylactic laser is done around the site. Any bleeding which is happening during the time could be controlled by diathermy or increasing the infusion pressure. So to understand the chorioretinectomy better, I just present this case of a 28 years old male who had a double perforating injury in his right eye. So we did a lensectomy. He also had some endophthalmitis along with it. We did a lensectomy. We cleared the wound site. We sutured the wound. The wound was then sutured. After that, the vitrectomy was completed. The hemorrhage was removed. The vitrectomy was completed. And you see there was an exit wound seen just along the inferior temporal vessel. So at this moment, we did not want to touch the retina, because there was also an endophthalmitis component there, and we left this vitrectomy at this point, and we closed the eye. But 2 months later, there was a thick fibrous growth from the exit wound extending up to the fovea, and the best corrected vision was counting fingers at 1 meter only. Then we took the patient up for a second step, in which we performed this epiretinal membrane removal. And after trimming this epiretinal membrane, you see I'm giving these 100% diathermy burns around this exit wound. So you have to go up to the level of sclera, and then the choroid tissue is being melted away by the diathermy itself. You can do it with the diathermy, or if it is not coming, you can use even the cutter to remove the choroid from this. You see, you have to go till the sclera shines through it. See, now you can see the sclera which is shining through this choroid. And you complete this, you have to spare the major blood vessels. You cut the major blood vessels, otherwise there will be uncontrollable bleeding. No, sir. In fact, if there is a choroid penetration in that area, it means that the artery is not especially these type of cases where there is a PVR happening after the first surgery, you already have this PVR. If you take a second chance, again the fibrous tissue will proliferate.
Yes, today is the point.
Yes.
Thank you.
So after this, the gas was injected and the surgery was completed. So this is post-operative. 20 days post-operative, the best corrected vision improved to 6 by 24. And 2 months later, it improved to 6 by 18. Although there is a component of branch retinal vein occlusion, but still the patient was maintaining a good vision at that time. And this is 1 year. So post-op, you can still see that the patient is maintaining a good 6 by 18 vision 1 year post-operative. Though there are no recurrent PVR. Yes. Yes.
During the video, I saw that.
Yes. So this is another patient. This is a prophylactic now chorioretinectomy. I'm going to show you. This is a patient of 21 years old male, perforating eye injury with intraocular foreign body, which was impacted into the choroid. So after removing the vitreous hemorrhage, this foreign body was released, and again around the wound side, the chorioretinectomy, 100% deep diathermy burns were given, and the choroid and retina simultaneously they were removed. So you have to be careful that these 100% diathermy burns should be done, because sometimes what happens is you just see the point coming and you stop the diathermy over there only, but you have to press the foot completely so that 100% diathermy burn happens. So now you see I am excising the choroid tissue from this area. Some amount of blood may ooze from there, but it will stop by increasing the infusion pressure. And if needed, you can do a diathermy at these points. Now the foreign body was lifted from the retinal surface, was transferred to the foreign body faucet and was removed through a separate sclerotomy, which was made for the removal of this foreign body. Then a fluid air exchange was done and endolaser was done. I prefer, though Dr. Ferenc-Kuhn says no laser is needed around these chorioretinectomy sites, but I prefer to give 1 to 2 rows of laser around, especially if the wound is away from the fovea. So these are the post-operative pictures of the same patient. Vision improved to 6 by 6 post-operatively. This is another patient, a 32 years male, injury with a knife, and he had a RD with vitreous hemorrhage and vitreous incarceration. And so in this patient, again, the vitreous hemorrhage was first clear, and there was a lot of vitreous incarceration. So in this case, you can't create a chorioretinectomy which is too large. This may be dangerous sometimes. So in this case, what you do is like you create around the vitreous incarceration site, you just give all these 100% deep diathermy burns. So you can let me know when the time is up. And once you have done this, you can trim the vitreous incarceration to the maximum, and then you create a 1 to 2 mm strip all around the vitreous incarceration of chorioretinectomy of the Bayer sclera, and this also prevents the later development of PVR. I'm doing retinectomy because it is a detached retina. So I'm now trimming the incarcerated retina and the vitreous. And now this is how I create a 1 to 2 mm strip of Bayer sclera all around this incarcerated site. Doing this, the rest of the surgery, you see the addition of RD with You can ask me in between also. So once this is done, again fluid air exchange was done, and we use silicone oil as a tamponade in this eye. The laser was done around the retinectomy site, chorioretinectomy site, and also 360 degree. A prophylactic barrage was given 360 degrees to the periphery. Then silicone oil was used as a tamponade. Yeah. And this is the post-operative, 2 months post-operative. The best corrected vision was 6 by 60. 1 year post-op, improved to 6 by 36, and 2 years post-op the patient is still doing well.
Fantastic.
Yeah.
Otherwise, it could have been worse.
Yes, yes, sir. So these are few more cases. This is a large intraocular foreign body in which chorioretinectomy was done. This is an iatrogenic perforation, a perforation which was done, which I had during a patient treating it for diabetic retinopathy. After the first surgery, there was development of PVR, and after that, during silicone oil removal, we did a chorioretinectomy. Patient stayed well after that. So, patient who had a cow's horn injury. It was a total vitreous hemorrhage with anterior incarceration.
Can I interrupt?
Yes, sir.
The PDR case that you showed earlier.
Yes, sir.
What was the indication of chorioretinectomy there?
So during the first surgery, when we were treating the PDR with TRD, there was a accidentally my diathermy probe hit the retina and the choroid also accidentally, and from that there was a PVR development in the post-operative period. So while we did the silicone oil removal,
that shows up another indication.
Yes, sir. So it is like therapeutic use. So this is a double perforation again treated with yeah. So in the end, I'll just conclude. So chorioretinectomy is a relatively new procedure. It may prevent exit site wound related PVR and fibrous growth over the retina from the wound site, and it may be considered as a prophylactic or therapeutic option. Thank you.
Terrific, Sangeet, as usual. Come have your seat here. Take your seat. Aditya, take over the next topic. Aditya Kelkar.
Thank you, Dr. Jayanto, for this honor. And I'll be talking about my experience of management of choroidal hemorrhage. So at times when patients present to you post trabeculectomy with these type of serious choroidal detachment, usually the line of management is medical line of management. But we do come across situations such as this on table. So I will be discussing some of them in front of you. Yeah. So the choroidal effusion can be of different types. One is the abnormal accumulation in the suprachoroidal space can be serous, which is basically due to hypertrophy. Patient who doesn't have any severe pain is usually managed with and often sight threatening and can cause sudden loss of vision due to increase in intraocular pressure. So this is the first patient with 40-year-old male road traffic accident 2 days ago. Counting fingers 1 meter and 3 meters posted for explant and on the temporal side. So we were explanting the lens temporally. So as I enlarged this incision, you can see something coming on the inferior side, bulge, brownish red color. Lens is half haptic also plays. This infusion has started. So I removed the cannula immediately. The main cause of choroidal effusion is hypotonia. So first thing that we did was to suture the wound, and then I introduced the cannula on the nasal side. And these are all cannulas which we use are the valved cannulas. So all that you need to do at times is only just remove the
At that time, intraoperative hypertrophy was continuing.
Yes.
So I saw that you shifted the cannula after
nasally.
suture.
Yes. I could have done that, but at times what happens is that while you are still, the wound is open and the infusion is still on, that time the vitreous starts hydrating and starts prolapsing through the wound, causing causing the retinal detachment there. So after I have stopped the cause for choroidal effusion, which was the cannula that had slipped inside, I sutured the wound and then I shifted the cannula on the nasal side. And then because these are valved cannulas, it doesn't allow easy drainage of the suprachoroidal fluid. So then this cannula, as you can see, there is a gush of fluid and the choroidal immediately going back without much of an intervention. And then we can go back to our surgery and do a secondary IOL. Here you can see it's completely vanished. The suprachoroidal hemorrhage is gone. You can see the blue is much better. So obviously we are not lucky all the time, and there is a situation Alternatively, the doctor noticed suprachoroidal hemorrhage with drainage sclerotomy is also done, but wasn't that useful. And the visual acuity hand movements, corneal edema, shallow IC, and the tense, painful eyeball. This is the B scan that shows hemorrhage. This is 2 weeks. So we stopped his anticoagulants after asking the physician 1 week prior to surgery, and then I did vitrectomy with suprachoroidal hemorrhage drainage under local anesthesia after cardiac fitness. The cornea was already edematous, so we removed the corneal epithelium. Took a parietal suture because I wanted to expose this temporal area. A cementer has been placed, and then about 7 to 8 millimeters behind the lummus, I made this radial cut onto the sclera till I see the muscle flow. Using the iris appositor, the entry side is pressed so as to allow more drainage of fluid, more drainage of blood. When I go back in with 25 gauge parchment vitrectomy, there was an element of vitreous hemorrhage also in this patient. So we cleared up the vitreous here. You can still see there is some choroidal on the temporal side still, but it is much better than how the initial view was. So I made another nick on the temporal side just parallel to it. So the second sclerotomy just to drain the residual blood that we were seeing right now.
Preferred a cut down method.
Yes. This is a huge choroidal hemorrhage, I think so. The conventional treatment worked here. Obviously use a cannula. So most of the hemorrhage was done in this fashion using the second sclerotomy. Just you can see that this blood in the center of the temporal choroidal detachment, hemorrhagic choroidal detachment has now settled, and this blood was then aspirated using passive and active aspiration of the cut. Patient regained useful vision within a couple of weeks' time, and since he is single-eyed, he is at least now ambulatory. At the end of the 6 months, I've been seeing him regularly. He's about 624 vision and he's seeing eye. His cornea is cloudy, probably due to that endothelial damage that he has suffered in the last pressure since last since about a week or two that he was high pressures. Removed this nasal cannula, some more choroidals got drained, and the glow now looks much better. And ultimately, anterior chamber is formed with air. And this is his post-op fundus picture in the first week.
You know, Aditya dealing with these situations more often than us because he does a lot of, and he's a known exponent of scleral fixated SFIOLs, Aditya. So maybe these situations come to him more often.
Yeah, that's true.
Thank you, Aditya. Come.
Thank you, sir. Thank you.
Yeah. Yeah, please.
Chief Instructor Dr. JAYANTO to discuss his experience on subretinal PVR changes.
And it's an honor because these are doyens with whom I am presenting this course. So irrespective, I mean, thank you so much for staying on. So subretinal PVR, as we all know, this is a very funny slide. It says, unfortunately, I have no financial interest any of the products. This is mandatory slides. In Thessaloniki, we are training that I go to often. Professor Athanasius wants us to present this as a second slide and use the word unfortunately in case one doesn't have any financial interest. So anyway, basic principles of surgical treatment of detachments complicated PVR are those of detachment surgery in general. That is the closure and sealing of all retinal breaks and the complete and thorough release of periretinal traction. Peri means both epi, intra you can't release, and subretinal. So to these can be added the mirage of prevention of recurrence of the proliferative process and its ensuing tractional forces, which as I said remains a mirage. Subretinal membranes, also known as retroretinal bands or membranes, are a well recognized complication of detachments and trauma, and as such are a part of the spectrum of the whole PVR spectrum. In this process, pathophysiologically, RPE cells migrate from the normal monolayer into the subretinal space, undergo metaplasia into macrophages and myofibroblast-like cells that proliferate as sheets or bands. If they proliferate as sheets, these are diffuse sheets which lack collagen usually because they compose of glial cells. They don't contract much and they don't prevent as such retinal detachments in general. But if they form bands, they contain myofibroblast and they form an annular configuration which raise the neuroretina and impede attachments. These bands require division or removal. Morphologically, they can be subclassified into annular strands, linear strands, and moth-eaten appearance sheets, as is depicted here pictorially. The slide on the bottom right sometimes confuse you as a epiretinal fixed fold, but they contain, so one has to be very careful, one has to examine it under zoom and use DDMS, and before trying even to peel the epiretinal bands, there exists no epiretinal membrane but a subretinal membrane contracting from below. So one has to be very careful. I just wanted to highlight this picture because this is a confusing thing, because one can tear the retina apart in the absence of any epiretinal membrane. You are going for an invisible ERM. Good to stain in these circumstances to be on the sure sides. Clinical key points are that bands have to be removed, but even bands do not always prevent reattachments. So one very good sign, a test thing is to put PFCL after you have released all your epiretinal traction and see whether those subretinal bands need to be removed or not by using PFCL, perfluorocarbon. When removing subretinal bands, it is important to select a location that maximizes access and leverage on the band. That is where the band is thickest, you identify. Never use diathermy over a band to create a retinotomy, as this can sever the band. There are several techniques are being described: spaghetti maneuver unimanually, or bimanual with a pick and a forceps, or with two forceps with a hand over hand technique, as I will show in the video. Principle is to maintain a wide angle system. Do it in a wide angle system, so you are visualizing what the remote effects, remote peripheral effects of your localized peeling is doing. Because if you are not careful, you can create iatrogenic complications if you are not careful of the remote effects of your localized actions. For that, a wide angle system is necessary. Never lose access by breaking the band, because tensile forces will cause the band to retract if you are doing it unimanually. Using a localized retinotomy. Sometimes, if you see the morphology of the bands, you have to take recourse to extensive retinotomy so that you have access to bands. And I will also describe a peculiar situation where extensive retinotomy is actually ideally required. So there has been a paradigm shift over the years, and I want to introduce the concept. Many people are aware of this concept. Dr. Cyrus had simultaneously more or less coined this term as tug of war for epiretinal and subretinal membrane peeling. So I also call it a tug of war concept by using either spatula forceps combination or two forceps combination and DDMS and flexi loop in various combinations. You can of course use the PFO to provide contraction. These are the pictorial depictions. I won't go. Last word before the video is ab externo subretinal PVR removal. I remember Rupokanti is a great advocate, my good friend, of ab externo PVR extraction. So it reduces, I haven't tried much, I'm still learning the process, but reduces the number of operations needed, avoids the visual impairment caused by multiple surgeries, they say, the advocates of ab externo. But patients with extreme PVR, significant epiretinal membrane contractions, prominent retinal shortenings, and especially shallow detachments, these should be avoided. People do both ways, but I feel technically membrane removal, ab externo, and then vitrectomy is preferable. Area of highest detachment is identified, and trocar is advanced at a 15-degree angle to pierce the retina choroid in this area, and then cannula is visualized to be placed in the subretinal space, and forceps are advanced to access the subretinal bands. The band is then grasped and pulled out of the eye. Be very careful. Retinal injury and subretinal bleeding is often possible in these situations. And as I repeated again and again, the study, the macular, if the bands are extensive bands approaching the macula, encroaching the macular area, best, because these are often attached to the neurosensory area more than to the RPE. So you have to see it visually, as I will show in the video, even submacular bands, to detach them very carefully so as not to injure the neurosensory retina more. So when bands stopping short of the submacular bands, you use the ab externo. These are the pictorially these techniques ab externo. The light is, the forceps is introduced, and a chandelier illumination is there, and through a trocar cannula, you are just ab externo. From the scleral side, you are removing the band. We go to the video straight away. Localized, I am not a great fan of doing posterior retinotomy, posterior to the equator and removing the bands. If it is anterior to the equator or near about the equator, yes, I am okay with it, as is these cases. But posterior retinotomy, as Sangeet would agree, PVR, inevitable. So these are the cases where there was extensive areas of attachment of the bands. So bimanually, they are being removed after an extensive retinotomy. Much easier to go right, even required up to the disc area. And under direct visualization, you very carefully dissect these tissues so as to cause least injury to the neurosensory retina, which is the most important area to be preserved in such cases for your postoperative vision functional recovery. You use a various combinations of ILM peeling forceps, end grasping forceps with two hands. Sometimes these bands are just beyond the retinectomy, so as in this case. So you use a tug of war method, tangential. The principle is to keep it tangential, not to use the other vectors in the other directions, 90 degree, tangential to the retina. Be tangential retina, move your forceps till you feel comfortable. Sometimes you use a DDMS to release the folds after releasing the membranes. That's the end result after the extensive membrane peeling is done. The next case, again extensive. The last case, I would combine. Here I am using a spatula initially and then two forceps. The last case, it was a multiple surgeries elsewhere, huge macular hole, more than 2000 microns. I had combined a retina transplant along with that, as you would see. So you can see, you can go right up to the macula and very safely peel those membranes under direct visualization, causing least injury. But I will definitely try out the ab externo in future with restricted indications. So use a hand over hand technique sometimes, use it tangentially, but essentially it's a tug of war technique. It's a tug of war going on to release these membranes. Very short video. So in another area you start, because these were all extensive membranes. So you finish one quadrant, go on to the other quadrants until the whole. Sometimes you have to go on putting PFCL, reattach the retina. Here the last case, combined with retina transplant, multiple surgeries elsewhere, I think 5 to 6 times, and we release the membranes. The retina was already foreshortened, as you can see, those diathermy previously lasered areas, where I had to again redo the retinectomy. Those areas. Sorry for the sound. And we are putting a retina transplant here. And the last, just few more seconds, last, few seconds, 2-3 seconds. Foreign body, and with a subretinal membrane, after removal of the foreign body, Here there was a pre-existing tear through which the foreign body went in. You just remove the membrane through that retinectomy and complete the case. Thank you so much for your kind attention.
And inviting me in your course. So this is the my topic is suprachoroidal hematoma and drainage techniques. Sometimes in a lifetime situation, this kind of situation may be faced by every surgeon, every one of us. So intraoperatively, just after cataract extraction, sudden hypotony may induce onset of suprachoroidal hemorrhage. Sometimes it becomes almost painful experience, like everything will be coming out from the your whenever it finds its own weakest way. So this was the video of live demonstration of how expulsive can happen from my own good friend Dr. Sumen Bhattacharya. So I will talk about the drainage techniques as well as the what is the brief idea about the suprachoroidal hemorrhage. It is a rare condition defined as a collection of blood in the suprachoroidal space in between sclera and choroid. The incidence is very rare, 0.04 to 1%. And actually it is not a space, it is a potential space where there is the normal volume of the suprachoroidal space is 10 microliter of fluid it can accommodate. But when there is any rupture of the any arteriosclerotic vessel or any kind of trauma that can induce the collection of blood in this space. So I will talk about the postoperative suprachoroidal hemorrhage. Predisposing factors reported for the development of SCH includes advanced age, glaucoma, increased axial length, systemic cardiovascular diseases, non-phakic condition, that means aphakia or history of vitreous loss. And current indication of surgical drainage of SCH is extreme pain, a persistent flat anterior chamber, uncontrolled elevation of intraocular pressure, retinal detachment, central choroidal apposition, that means kissing choroidals or retinal vitreous incarceration in the wound, or inability to deposit the intraocular contents. So intraoperatively, just after removal of cataract, the signs of expulsive hemorrhage could be the bulging forward of the iris diaphragm. These are all like these are all warning signs of expulsive hemorrhage. This is going to happen. So vitreous starts swelling out of the limbal section, iris will prolapse out, and there is glow will be lost, and seepage of prolapse of vitreous through the wound. So easy breaking of suture while you are closing the wound. So primary management of intra-expulsive hemorrhage, it's a tight closure of the incision. Posterior radial sclerotomy that I've already described by Dr. Aditya, and anterior radial sclerotomy that is also possible either in 1 or 2 quadrants, 10 to 12 millimeters posterior to the limbus on either side of the superior muscle. It is very easy to perform. So postoperatively anytime till 2 weeks. So ideal time for drainage where the clot lysis is happening, that means 7 to 14 days after primary surgery. Within 7 days, if you want to do this surgery, you have to use the help of subretinal suprachoroidal TPA injection for the clot lysis. Otherwise, natural clot lysis is happening. It is happening after 7 days.
So
for the secondary
sorry to interrupt you.
Yes,
because this is a discussion by interruption. So at this stage, you would do a serial ultrasound.
Yes.
To observe the unless you have recourse to TPA. So answer this question plus whether you have any experience of using TPA if you have to drain before 14 days, before liquefaction.
No, I have never used TPA for the suprachoroidal hematoma. All the cases are done for the submacular hemorrhage, but for suprachoroidal hemorrhage I have never used. But if people can use it, this is another option. So for secondary management, early referral to peer colleague, he will assess the case and he will do serial ultrasound. Dr. Guha was telling that you have to do the serial ultrasound to go for the evidence of this clot lysis. So surgical management described earlier, it was the radial sclerotomy combined with vitrectomy and use of perfluorocarbon liquid. The standard surgical technique, Dr. Aditya Kelkar has already shown, that's 2 to 3 millimeter sclerotomy. Sometimes and you can introduce cyclodialysis spatula for the better.
How many millimeters from the limbus?
It is the if you are doing anterior sclerotomy, you can do it the parsular region, or if you do the posterior sclerotomy, 10 to 12 millimeters away from the limbus.
10 to 12.
Yes.
But vortex veins, any consideration? Vortex veins?
What?
Vortex veins location, any consideration?
Vortex means that either side of the suprarectus muscle is the ideal side for the drainage. Avoiding the vortex vein is obviously. So use of anterior chamber maintainer and SCH drainage through the anteriorly placed 23 gauge cannula followed by vitrectomy with PFCL and ending with silicone oil. It has already been described by Dr. Rosie T et al. In 3 cases. So our technique was to introduce PFCL from inside and posterior the passive drainage of suprachoroidal blood. It was our modified technique, and I have used it in our initial 15 cases that we have already published in IGO. This is another. It is one case where I am trying to push it's a very old video using the 23 gauge cannula, and remaining lens matter was there, almost kissing choroidals. Now the choroidals has a little bit decreased while doing the surgery. Now I have seen the intravitreal picture of the thing, and now you just see the cannula was quite old, and after vitrectomy I am introducing this PFCL, and you can drain the suprachoroidal blood, and you can see the tip of the cannula by using a Sandler's light or by intravitreal illumination. It is not mandatory to drain all the blood, suprachoroidal blood intraoperatively, and at the end of surgery.
That's very important.
It is not mandatory to use to drain all the suprachoroidal blood. That is, it is mandatory because rest of the blood you have initiated the drainage first, and it will be slowly drained. It should slowly resolve in the course of time.
Do you suture the sclerotomies?
No.
Good.
No, it's absolutely sutureless. So this is another case where this is the post-op picture of the same case where final BCVA obtained after silicone removal logmar 1, that means 6 revision. This is another case where there was squishing choroidals, hyphema, and kissing choroidals, hyphema. I tried to introduce all the ports here, and it is mandatory to see the gas of blood is coming out after the introduction of the left-sided port, and then introduction of this right-handed port is quite cumbersome because the choroidals is also boggy here in nasal. The temporal side, you can see the maximum elevation from the maximum elevation, the elevated side by which was pre-operatively should be guided by the ultrasonography. And just see, I am just draining the blood. After doing vitrectomy, injecting PFCL from inside, and external passive drainage of blood was possible. At the end of surgery, remove all the PFCL bubble and inject silicone oil at the end finally. And you can see there is improvement in the glow, and post-operatively you can see the complete absence of suprachoroidal blood. And ultrasonography patient, although didn't get too much of vision because the choroidals was almost involved, the macular part, it was not, it's still persisting, and after 3 months of the BCVA, it was showing logmar 1.3, that is 3/60 vision. Silicone removal was not done. So in this case is a one quadrant suprachoroidal and hyphema. So after initiating the surgery with AC maintenance, I tried to
Subhendu, just pause.
Yes.
So just for the sake of the audience, CC, anterior chamber maintainer has such an important place in this because you do not know the extent of the choroidal detachment.
Yes.
Interiorly. So safest is to begin with an anterior chamber maintainer to keep up the pressure. And Subhendu, second question, have you tried using Helon? Suppose there is no indication of doing a vitrectomy.
Yes.
So there would be cases where vitrectomy would not be required. A simple ab external drainage would suffice.
Yes.
In those situations, because once you start using PFCL, you have to do a vitrectomy first and then use PFCL.
Yes.
Without vitrectomy, PFCL cannot be used, as is sometimes the notion among the people who are beginners. So you don't have to do a vitrectomy. In those situations, would you use Helon?
No, I have never used Helon.
Okay.
You can use it.
Yeah.
So so I am just draining this black colored suprachoroidal blood, you can see. So after completion of this vitrectomy, I am injecting PFCL and external passive drainage of blood after introducing multiple sutureless, there is no valveless 23 gauge cannula. I am just removing all the black colored blood, and finally I remove the silicone PFCL and injected silicone oil in end of surgery. After 3 months of this surgery, I removed the silicone oil and used gludal for the completion of the case. So after 3 months of, you can see the expulsive has totally gone, and finally patient gained 6/12 vision. So this was the case pre-operatively. You can see Here you see the preoperative picture, and postoperatively blue dial is absolutely centered. Complete absence of suprachoroidal blood in the ultrasonography as well in Optus picture, and patient gained 6/12 vision. So this is another case, more hemorrhagic kissing choroidals and along with total retinal detachment. Here I am using 23 F gauge port and one the Chandler slide 25 gauge, and checked my infusion whether it is inside or not. You can see the retinal detachment is there, and you can see the slit-like break in the supratemporal quadrant, 2 slit-like breaks. So sometimes it is very much mandatory to mark your break because you will easily miss it. Try to find out the disc is here, not much of PVR. So PVR you may or may not get, and after doing vitrectomy, descent vitrectomy, PVD is usually it is happening in most of the situation. So I am injecting PFCL and try to drain the subretinal fluid through the same slit-like opening, and while you are removing the subretinal fluid, you can see the actual elevation of the suprachoroidal hematoma. So it was not much at that time, so I try to drain the blood from external side, and you can see after completion of residual vitrectomy and little bit of vitreous base excision, I introduced the port 10 millimeters behind the limbus with the help of 23 gauge null valve cannula. Removed the trocar first and tried to drain the blood. Little bit of blood was coming out, and then I settled the retinal detachment, and postoperatively you can see it was the preoperative kissing choroidals. Now postoperatively choroidals has not gone, but still I have not removed the oil in this case, but later on it will be slowly resolved. It will be resolved after 3 years of surgery, because I have used 5000 centistroke silicone oil. After 3 years of surgery I removed the silicone oil, but patient was having
Why did
some
you
kind
use
of
5,000?
5000 because not to remove the oil so early, not before 6 months. So after 3 years of surgery I removed the silicone oil, but still the patient was having some kind of hypertony postoperatively. It was not removing even with diflured. So good prognosis case, you should consider 1 or 2 quadrant suprachoroidal hematoma along with the vitreous hemorrhage, not much of retinal detachment, so you can gain good result. And bad prognosis case where the retinal incarceration is there and a lot of like kissing choroidals, these are all bad prognosis case.
Take your time. Take your time.
Yes, retinal incarceration is another thing where your prognosis is not good, because although I have treated the case very well, like in this case after intervention done after 10 days of surgery, and after 3 months also, it is, you can see the poster picture here. Retina is nicely attached. It was a case of retinal incarceration, but still the patient was having the hypertony, persistent hypertony. For that only I have not removed the silicone oil. So these are all bad prognosis cases. You will not get good result. Thank you.
Thank you, Shubhendu. Great. Come.
I have couple of cases more because I after the series in IGO, but I have managed
Using the
couple of
trocar
cases.
cannula method.
Yes.
Yes.
25 gauge or 23 gauge.
So which
But
one you prefer, 25 or 23?
Today 25 is good enough.
Good enough.
You are getting
Only the
non-valve
reason
or
would be the
valve
clot.
cannula. Yes, valve cannula you can use it in the infusion port, but non-valve cannula you can use it for the drainage.
And also you can remove the valve by a cutter,
Yes.
with a cutter,
Yes.
and get rid of the valve,
Yes.
and then use it for drainage.
Yes.
In case your
Make it
hospital allows
non-valve.
you to cut the valves.
Hospital will allow you. Everybody, nobody can stop it.
Good. Come, Shubhendu. Great presentation. My good friend Professor Ramandeep is next. Ramandeep is a great surgeon, and he is instrumental in, along with Dr. Vishali, in the great work that they are doing in Advanced PGI Center in Chandigarh. And Dr. Ramandeep is going to speak on chorioretinal biopsy. Over to Ramandeep.
Biopsies, and if you this is not a very extensively done procedure, but one should know that when do we do it. So indications are when we are trying to decide whether it's a infective etiology or a immunological etiology, where you need some kind of a biopsy there. and if you are treating an infection extensively and it is not getting treated, you want to exactly know that what is this thing. So you want to take chororetinal biopsies, and if you don't have any cells in the aqueous or in the vitreous, so they are not going to help you. So help has to come from directly from the tissue if the retina and choroid are involved. And now the latest is people have added that in case of small melanomas or large melanomas where they are treating these patients with without enucleation, they are trying to take tissue from every sample of melanoma because it helps in the prognostication, because there are various gene expressibility proteins are there which will tell you that prognosis of a melanoma patient. So that has become another indication. So this is the gist, this is the chart which is very important, that the chororetinal biopsy can be done ab externo or it can be done through intravitreal route ab interno. So I'll start with the transscleral route. So either you can go, kind of a FNAC. We used to learn that fine needle aspiration biopsy, like what the surgeons do, and directly impale the lesion. And this is characteristically done for the lesions which are anterior to the equator. And so the external route is for anterior to the equator, and it can be done FNEB, or a transscleral biopsy can be done. Like in this case, a transscleral biopsy has been done, and you will see that we do a partial thickness scleral flap in this patient, and then under that partial thickness scleral flap, the full thickness of the sclera and the part of the choroid we are interested in is taken out. And why it is important to leave this partial thickness, we can suture the globe, and in case it turn out to be a malignant lesion, you can put a plaque over this lesion. That is very important. And if it is a malignant lesion, your malignant cells will be sequestrated within the sclera, so it will not come out into the conjunctiva. And of course, we are using the precautions like distilled waters in these patients. And similarly, in a FNAB also, people use raise a scleral flap and then enter through the sclera. And then, of course, from where they have entered the needle, they just cryo that site. So this happens for, this is useful for the anterior lesions. And this was done in this patient, and we were suspecting between a tubercular lesion or a melanoma. Classically, it was not fitting into a melanoma. Patient had a history of TB there. It turned out to be a tubercular lesion than a malignant lesion.
Yes, sir. Filter paper you are using.
Sorry, sir?
Taking out that sample.
Yeah.
Print out a filter paper.
Yeah, we'll take it on a filter paper, and then we have to put it in the the special media there, and then send to the histopathology. That has to all it will just send in the formalin actually. So the next method is transvitreal. So if you have a lesion which is posterior to the equator, that is amenable to the your vitreous cutters, and those cases you go transvitreal. So if you in the transvitreal also there are approaches like, if you see this, whether you want a full thickness retina or a full thickness choroid or not. If you don't want that, you can do a transvitreal fine needle aspiration biopsy, or you can do a biopsy using a simple 25G or 27 cutter. And that biopsy can also be without PPV and no PPV. I'll tell you how it is done actually. So this was a 27G vitreous biopsy without pars plana vitrectomy. This was propagated by Dr. Prithvi from San Francisco. So this technique I have used in few patients. So we don't do full vitrectomy there. We use 27G trocar cannulas. We use our bold cannulas, and directly we impale the 27G cannula into the lesion actually. So once you impale, absolutely just like a needle. You don't need a needle. You just go inside and impale it, and then you switch on the cutter with a low cut rate, and because you will get a sample there. No infusion, no need of infusion also. You just, because you made these ports to see your endolite where you're going. So because it is not done with the indirect ophthalmoscope, But yes, there was a group who was doing it with the indirect ophthalmoscope also, but that was a fine needle aspiration biopsy. This is a more controlled procedure because you're using 27G trocar cannula and you just impaling into the lesion and taking the biopsy, and while coming out you are not cutting, because that moment you'll cut the retina. You're not supposed to cut the retina. If it bleeds, so just increase the bottle height, because there the role of infusion, sometimes people put infusion to increase the bottle height. So I two cases I used air instead of this thing, the fluid there. I'll tell you why. Because air also, you can raise the pressure and the air bubble will go inside. It will not you will not ending up putting the fluid inside the eye.
You operate the cutter
Yeah.
while inside the lesion.
Inside the lesion.
And
You
then
inside the
and then
lesion,
take it out.
take the sample and then take it out. You don't have to laser the lesion. You just leave the eye like that.
In the sample,
Yes.
then you can use your infusion pressure or air, because there is
Absolutely.
no fear of dilution. Also.
Absolutely. And the only thing which has to take care, you have to cryo the ports you have made in these lesions if you are suspecting a melanoma lesion. So second is now with PPB. So if you have a lesion which is less than 3 millimeter, where you know that it's more like it's not a solid lesion like lymphoma. It's more of a solid lesion like melanoma. It's more of a lymphoma lesion which is masquerading as uveitis. There you use the PPV method. So here is the video of this, how this is done. So again, to emphasize, because we want to take the samples of the vitreous which is undiluted. We don't infuse the infusion cannula with the fluid there. We straight away start with the air. So we will take the undiluted vitreous samples and do the vitrectomy under air. And this is done with a low cut rate so that you don't destroy the cells there. Approximately 2.5 to 3 cc of vitreous can be taken under the air, and you don't have to just have to do it slowly. And you take samples from the anterior vitreous, mid vitreous, and the posterior vitreous, and label it and send it that way to the person who is. This is vitreous biopsy. This is vitreous biopsy. And after you have completed the vitreous biopsy and the vitrectomy, then if you want to take a subretinal biopsy, to see with the laser, I've made a retinotomy there. Now with the aspiration tip, now I have taken a sample there. So this is how you take a subretinal fluid, and this is the kind of a needle is being used. So if you're using a 25G cannula, you don't have to, you have to laser it and leave the eye under air. And of course, you have to complete the vitrectomy and remove the hyaloid before you take the sample. And sometimes you have to put the gas in these eyes also.
You think that soft tip cannula should GUHA, that is sufficient, or you have to sometimes?
I think it is more than sufficient, sir, with the soft tip cannula, because you are making in the area of the lesion there. You can take it with the 25G cannula.
Sometimes people also use bimanually forceps and scissors.
No, so that is for the full thickness. So this is for the subretinal fluid only, where you are planning to take a subretinal fluid, which is.
What is the indication of full thickness?
In the full thickness indication will come where this procedure fails, or you are directly involvement of retina is there or the choroid is there. In this case, we know that lymphoma cells are in the subretinal space. There is no need to take that. So if the biopsy fails in this case, then I will take that. Otherwise, subretinal fluid is sufficient in these patients. And sometimes even I have used now a controlled active aspiration using a 39G cannula, also using a vitreous fluid extractor to take the samples in these patients, because that is a better controlled procedure and you don't have to laser it sometimes also. For the cytology. And of course, this is another video where it's just a use of microscopic the integrated OCT has been shown, that how the OCT shows that how with the aspiration the cells are literally moving into your silicon tip cannula. It shows that yes, you have taken sample from the right place, but it is not required in all the patients. Just to show you that how OCT will tell you that you have taken a sample, an adequate sample has come for the cytology in these patients. Yeah. So this is the indigenous, thing you have to make, so that your assistant will aspirate while you are doing a cutting there, and the cutter, the aspiration tip is put to the 2 cc syringe. Yeah, absolutely the same way it has been done. And of course, once you have taken the samples, before taking the samples, you should know that where all they will be going. So they should be labeled and put in the ice box if you're taking the cytology samples, and then sent to the person concerned, because he is the most important once you have taken the samples. They are not present in the OR, they are just less than a kilometer away, sir. So that is the advantage of being in a center. So that is the first thing. If you are planning to take these retinochoroidal biopsy, you have to have a person who is going to look at these friendly to you, nearby you, and you should be ready with the media and wherever you want to send. So if you are not, if you don't have this kind of a teamwork, please don't do these procedures. So next is, as you said, sir, where to take full thickness biopsy. So if you have a uveitis infiltrating lesion, if you have a retinochoroid, both is involved, and if you have a tumor less than 3 millimeter of the biopsy have failed now. Now there you will take a full thickness lesion. So this is a patient where we have, somebody has given Ozurdex also in an infectious patient, but despite everything, we were not able to control the infection. So this patient actually landed up with vitreous hemorrhage and a subhyaloid bleed there. So we took him for surgery because of the vitreous hemorrhage and bleed. And we thought we might be able to take the biopsy now, since the bleed, we are already going into the vitreous cavity. So you see this patient, after clearing the vitreous hemorrhage, the subhyaloid bleed was cleared after making a small hole in the hyaloid there, and you will see that there was a lot of blood there, and eventually we were able to see the retina. So this is where we plan to take a retinochoroidal biopsy. A demarcating laser is done. We always take the normal retina also and the diseased retina also. This helps the histopathologist to see it actually. So we need to do a hybrid kind of a thing, because the vertical scissor comes in the 20G, and we make a fourth port and then go inside, like Dr. Sangeet has done the 100% diathermy. Now we will be cutting the retina and the choroid both. So if you want retina, you can take retina only, but if you want retinochoroidal biopsy, you can take both, and you will be seeing some bleeding, but the bottle height can be raised. Eventually, retina and the choroid both will separate from each other, so you can take them out, one piece after the other. So this is how you see the bare sclera there, and some bleeders are there. Now we have held the choroid there, and we'll take it out with the
Ramandeep, in this case, you decided retina and choroid biopsy.
Absolutely, sir. Retina and choroid biopsy.
Indication?
Because it was a retinochoroidal lesion. It was a retinochoroidal region. So this was that was the choroid. Now this is a retina coming there. So this is how you take a retinochoroidal biopsy, and then after doing a fluid gas exchange, because this was a superior thing, so you can put
what forceps you used?
This was the vertical scissor, sir.
Scissors, but to pull it out, what did you use?
Sorry,
to pull it out.
Grasping, sir.
End grasping.
I don't want to use ILM because it will,
that's the point I wanted to
traumatize it. And grasping is always better.
That's what I wanted. Yes.
So this is how the patient looks like after the surgery, and eventually we were able to show the toxoplasma in this patient actually. So once you do CRBs, I think the diagnostic the rate range is 55 to 100%. Good labs will have 100% results. And again, I've told you the importance of the teamwork here, and who will assess the sample, and who will take care of all these patients. And complications do occur when you do these procedures, but they can be taken care.
So fantastic, President Ramandeep. Just one small query. You emphasize. Would you highlight? Of course, at the end we'll ask the questions.
Yeah.
But just one small one. What is the use of ultra wide field? Now that we have access to ultra wide field imaging modalities, multimodal. So, what is the role of there in assessing the preoperative biopsy site, assessing with the cytopathologists at that stage, the site of biopsy, how to choose the biopsy site? Please throw some light.
Ultra wide is not going to be effective. Really going to help in these situations. But yes, in uveitis we use ultra wide angiography and the ultrawide, the fundus photography a lot. So that is a different thing. But here, I think is just a better documentation is more important.
And lastly, you showed toxoplasma was the outcome.
Yes, sir.
So after that, in the postoperative period, silicone oil field eyes, the effect of oral toxoplasma drugs, could you compare that to? Just a sidelight.
No, it's a very important question, because we do nowadays in uveitis, we do a lot of vitrectomies there. So this is a this is a misconception that once you have a vitrectomized the eye, the anti-VEGFs or antibiotics or the Ozurdex injection is not going to work, or they will quickly be absorbed. But this is not true. So
the oral anti-toxoplasma drugs,
oral,
also
everything, the availability is good.
Choroid.
Absolutely.
All you have to take care is once the silicone oil is there, you have to decrease the dose if you're giving it intravitreally. But
what is your current indication for choroidal biopsy? Like, is it the infective and malignancy part, or anything else?
Sorry, sir.
What is your indication for choroidal biopsy? Is it the infective and malignancy?
It's infective and masquerading, obviously malignancy.
Yes.
These are the two indications which are there.
Okay. Any other indication?
Other than, sir, the indications comes that now the people are doing for the melanoma. For prognostication of the melanoma. Melanoma, I know that this patient requires a plaque therapy. But in West nowadays, before doing a plaque, they will take a sample just to prognosticate the patient, because nowadays, first the gene expressibility factor is there, and then the targeted therapy is there. If patient falls in that, then they will give plaque therapy also and targeted molecule also.
Okay.
Great. Thank you so much, Ramandeep.
Thank you.
We'll have all the other questions at the end. My honor to again invite Sangeet Mittal. Unfortunately,
There. So this is a this is a misconception that once you have a vitrectomized the eye, the anti-VEGFs or antibiotics or the Ozurdex injection is not going to work, or they will quickly be absorbed. But this is not true. So
the oral anti-toxoplasma drugs,
oral,
also
everything, the availability is good.
Choroid.
Absolutely.
All you have to take care is once the silicone oil is there, you have to decrease the dose if you're giving it intravitreally. But
what is your current indication for choroidal biopsy? Like, is it the infective and malignancy part, or anything else?
Sorry, sir.
What is your indication for choroidal biopsy? Is it the infective and malignancy?
It's infective and masquerading, obviously malignancy.
Yes.
These are the two indications which are there.
Okay. Any other indication?
Other than, sir, the indications comes that now the people are doing for the melanoma. For prognostication of the melanoma. Melanoma, I know that this patient requires a plaque therapy. But in West nowadays, before doing a plaque, they will take a sample just to prognosticate the patient, because nowadays, first the gene expressibility factor is there, and then the targeted therapy is there. If patient falls in that, then they will give plaque therapy also and targeted molecule also.
Okay.
Great. Thank you so much, Ramandeep.
Thank you.
We'll have all the other questions at the end. My honor to again invite Sangeet Mittal.
Actually increasing the spread of the malignancy inside the eye, is there any risk?
So the risk is always there. That is why we say that if you are for these regions, you have to trial them.
Okay.
If you're coming out, you trial them. Because they are already inside the eye. It's not like
It is in the posterior pole. There is no. It is very cryo is inaccessible for.
it is not like in the retinal blastoma, there is a vitreous seeding.
Yes.
It is not a seeding type of thing in melanoma actually.
Yes.
So if it is while you're taking a biopsy, you are passing through the vitreous. It comes into the vitreous, doesn't make any difference.
Okay.
You have to take it should not come into the projectile or some projectile.
There you cryo it.
So that you cryo.
Okay.
Thank you. We go on to the next speaker, Sangeet, and we'll have all the questions at the end, the remaining questions. Sangeet will be speaking. So his topic, submacular hemorrhage, Sangeet Mittal will be dealing with it. Over to you, Sangeet.
Thank you, sir, once again. And thank you for allowing me to cover for Dr. Nishikant Borse, who unfortunately could not be here. So submacular hemorrhage results from choroidal or retinal vessel abnormalities, and submacular hemorrhage frequently results from a choroidal neovascular membrane secondary to AMD. Other conditions associated with CNVM include myopia, trauma, ocular histoplasmosis, angioid streaks. They also can lead to submacular hemorrhage. And why do these people need early treatment? The presence of iron or hemosiderin and fibrin in the blood has toxic effects on the overlying photoreceptors. So clot retraction can shear and damage the photoreceptors. So physical separation of the photoreceptors from the RPE causes atrophy and can result in disciform scar formation. So all these mechanisms cause damage. They are time dependent, and early intervention is therefore generally better. So what is the classification of different types of submacular hemorrhage? They depend on their size and the extent. A small, thin submacular hemorrhage can often be observed. Thick, medium-sized subretinal hemorrhages that extend under the macula and obscure the underlying RPE can also cause significant vision loss. However, they are often amenable to treatment. Massive submacular hemorrhages often have a poor prognosis regardless of intervention. Some investigations, FFA is of limited use because the blood covers the underlying choroid and you're not able to actually differentiate what the cause. ICG is very useful in diagnosing the choroidal pathology, as in this case, the choroidal polyps were seen below this submacular hemorrhage. OCT is again invaluable in the diagnosis and management of submacular hemorrhage. It helps in deciding the best surgical option. So this was one case of retinal macroaneurysm leading to the hemorrhage at various levels, including the subretinal. But as you see, the subretinal hemorrhage was not as extensive. So we decided just to observe and laser the macroaneurysm. And this is 2 months later, the patient regained a vision of 6.9 without any surgical intervention. So the treatment options vary from case to case. Main aim is to displace the hemorrhage. If it is significant, the options are observation, anti-VEGFs, displacement using intravitreal gas, or surgical displacement. So observation can be done if the hemorrhage is very small, like sometimes it happens with the formation of the Lecker cracks or during a trauma. Anti-VEGFs are helpful in small or medium-sized submacular hemorrhages with CNVMs.
Just
Displacement.
1 second,
Yes,
Sangeet, stop here. Suppose a hemorrhage, very small, thin hemorrhage, is above the fovea.
Yes, sir.
So, would you like to use gas in those situations above the fovea?
Above the fovea. No, I won't, because then the placement of the gas bubble will make it come to the fovea.
Fantastic.
And cause the...
Go ahead.
So displacement using intravitreal gas, this technique attempts to physically displace the submacular hemorrhage out of the fovea using an expansile gas. The procedure is performed under topical anesthesia and involves an intravitreal injection of 0.3 to 0.4 ml of SF6 or C3F8, and then face down head positioning is advised for 1 to 3 days. It is a cheaper office procedure. You can do it in your OPD. Disadvantage is that it is a longer displacement time. More damage to the photoreceptors can happen, and it may lead to complications like vitreous hemorrhage, endophthalmitis, RD, or recurrent hemorrhage. So this is again one patient, a small submacular hemorrhage was being displaced just by injecting the gas alone. So this gas can again be combined with a TPA if the hemorrhage is long-standing. Again, the procedure is similar, just the TPA is added to the, intravitreal TPA is added to the gas. The surgical treatment is usually reserved for large or very large submacular hemorrhages. And in this small, this 41 gauge microcannula is used to create the retinotomy and inject a subretinal TPA injection. So this is a small video showing, we can have the audio in this, audio.
66-year male who had undergone multiple
Sorry. Can we have the audio, please? Yes.
.66-year male who had undergone multiple intravitreal injections of Avastin presented with persistent submacular hemorrhage. 27 gauge vitrectomy was done without base excision. Internal limiting membrane rescued using ICG dye.
I prefer ICG ICG dye over a film to dye in these cases because it gives you a better contrast to the presence of blood below. If the staining is not good, you will not be able to.
40 gauge microcannula was used to inject TPA into subretinal space. TPA is used in the concentration of 12.5 micrograms in 0.1 ml solution. TPA is injected till it covers whole of the submacular hemorrhage and reaches beyond the temporal arcades. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. Visual acuity improved to 6 by 36 after 2 weeks and to 6 by 24 after 4 weeks of surgery. The most common complication seen with this procedure is a macular blowout resulting in a macular hole. This is mainly due to the uncontrolled forceful injection by the assistant who is pushing the plunger while the surgeon holds the syringe. This also leads to shaking of surgeon's hand while injection. To overcome this, an automated subretinal injector can be made in the OR. A 1 ml tuberculin syringe is cut at 0.5 ml mark. Plunger is cut with a length of 0.1 ml longer than syringe. A small hole is made into the rubber of a 10 ml syringe. The cut tuberculin syringe is then fitted into the rubber. A hole is then drilled in the 10 ml syringe and its hub is removed. Tuberculin syringe prepared earlier is then fitted in this 10 ml syringe as shown. This apparatus is then connected to the VFI system on vitrectomy machine. The drug is filled into the syringe from top and microcannula is connected. The speed of the injection can be foot controlled. 42-year female presented with macro aneurysm, pre-retinal, sub-ILM and subretinal hemorrhage. 27-gauge vitrectomy was done without base excision. EVD was induced with the help of triamcinolone. Vitrectomy was completed. ILM peeling was done using ICG dye and the sub-ILM blood was washed away. Gauge microcannula connected to the subretinal injector was used to inject TPA in subretinal space. Notice the smooth injection and less shaking of hands in this case. Fluid air exchange is done so that air replaces about 60% of the fluid in vitreous cavity. Air is then exchanged with SF6 gas. The visual acuity improved to 6 by 12 at 4 weeks post-op.
So for very large submacular hemorrhages, we need to do an extreme surgery like a large retinotomy or a large retinectomy, removal of the blood clots and PFCL to settle the retina.
Hemorrhage and total retinal detachment with subretinal hemorrhage. To begin, the infusion was placed in the anterior chamber to drain out hyphema. Anterior vitreous was removed and it was made sure that the infusion cannula was in vitreous cavity. Vitrectomy with base excision was done. Special care is taken while removing vitreous in these cases as it is hard to differentiate it from underlying detached retina. Total retinal detachment with massive subretinal hemorrhage was seen once the vitreous opacities were clear. Endodiathermy was done in the temporal peripheral retina in order to perform a large drainage retinectomy. Initially, the bulk of subretinal blood was aspirated through a small retinotomy using a brush needle. This prevents overspill of blood in the vitreous cavity, thus obscuring the view. Retinectomy is then extended and the retina is flipped to reveal the subretinal space.
Peripheral as near the aura as possible.
Remaining subretinal blood is then removed slowly using backflush needle. Large clots are removed using vitreous cutter. One needs to be patient and remove as much blood as possible. This may sometimes take a lot of time and multiple attempts are needed for complete removal. Once sufficient amount of blood is removed, then retina is flattened using perfluorocarbon liquid. Anterior blood clots and the peripheral retina can be excised at this stage. Fold on the retina was straightened using a softer backflush. Endolaser was done around retinal breaks and a 360-degree barrage laser was done to peripheral retina. A direct PFCL silicone oil exchange was performed. 65-year-old female presented 12 days after cataract surgery with vitreous hemorrhage, retinal detachment, subretinal hemorrhage, suprachoroidal hemorrhage and a possible needle perforation. Vitreous hemorrhage was cleared. Below the hemorrhage, massive choroidals were present. 26-gauge IV cannula was inserted in suprachoroidal space at the point of highest elevation. Once the cannula is in the right space, the metallic stylet is withdrawn and the plastic cannula is left to drain the suprachoroidal fluid. After flattening the choroidals, a large retinectomy was done to drain subretinal fluid. First, the brush needle was introduced in the subretinal space through a small opening to drain the bulk of subretinal blood. This prevents the overspill of blood in the vitreous cavity. A chandelier light was inserted and PFCL was used to flatten the retina. This was followed by 360 degrees endolaser barrage and silicone oil injection.
This was the last case. This was the case I showed previously. This is after the first surgery and after silicone oil removal. The patient is doing well. 6/36. The patient who had massive hemorrhages. This is another patient, submacular hemorrhage. To conclude, I will just say that submacular hemorrhage is a potentially visually devastating condition, most commonly associated with CNVM due to AMD. Given its poor natural course, various treatment options have been tried with variable degrees of success, and as in all diseases, patient selection is paramount. Office-based procedures such as TPA or just intravitreal injection of gas may help in some cases. In extreme cases, you have to go ahead, do a surgery and remove the subretinal hemorrhage. But whatever is done has to be done early to prevent any damage to the overlying photoreceptors. Thank you.
We have some time for questions now. We start with Shubhendu, who has to leave now. Shubhendu, this is a 3-day-old B scan of a suprachoroidal hemorrhage, almost kissing each other. And yes, almost kissing each other. And you can see the hyperreflective echoes, not homogeneous ones, which suggest not a
to drain
liquefied.
or not to drain.
Yeah.
Yes.
So would you like to drain at this stage?
Basically, you can see there is not enough clotlysis has happened here. So you should wait for another 4 or 5 days and repeat the ultrasound. That what I was trying to explain, that you have to do the serial ultrasound to go for the whether it is there is clotlysis is happening or not. And when it is relatively less echoic, then only you can get the sign of clotlysis. Then only you can
dynamic.
Yes, dynamic ultrasound.
Fantastic, Shubhendu. So
Thank you.
Thank you, Shubhendu. Shubhendu has to leave. Wonderful, Shubhendu. Thank you for coming. So we start with Sangeet. Your topic on prophylactic chorioretinectomy. Sangeet, this is an example of a macular exit wound. Now this is an extreme situation. There is a macular exit wound. I have borrowed it from Dr. Sengul, who is a proponent of. So, would you like to do a prophylactic chorioretinectomy with such a macular exit wound, and what is your rationale, possibly?
So, even if the exit wound is involved in the fovea, the macula, I would like to do a chorioretinectomy.
Why?
Because
Take a mic.
Photoreceptors are already absent. So, if you think that you have a good visual, leaving those area, in that case, that is a myth. It is not true. In fact, this is going to lead to fibrous proliferation around this wound, and whatever the peripheral vision you are going to have will also decrease. So
Preserve the peripheral vision as much as possible. Otherwise, it will go into PVR and destroy the peripheral vision. Also.
Yes, sir.
Fantastic, Sangeet. So you answer this question also. This is a montage of such a hemorrhage, almost extending. You can call it a large, massive submacular hemorrhage, extending 2 equators, almost in 2 quadrants to the equator. What would your line of management would be?
So in this case, I would definitely
not much of old hemorrhage, mostly fresh and clotted.
Yes.
Not those old dehemoglobininized blood seen, mostly red, dark red. So
Still, I would go ahead with vitrectomy and do a subretinal injection of TPA and prone positioning.
Fantastic. We did just that, triple therapy. We also injected air as per Dr. Tamer's method, Grewal and Tamer. And this was the result. Unfortunately, it was a traumatic one. And
Traumatic ones do better. In fact.
Coming to traumatic ones, would you like to also use, because we continue with anti-VEGF therapy for a long time, even after treating the blood. In post-CNVM bleeds, post-PCV bleeds. But in submacular hemorrhage with traumatic, would you also use anti-VEGF?
At the moment of the vitrectomy?
At the moment of the vitrectomy?
No, I don't actually include the anti-VEGFs with the subretinal TPA. If I need to give an anti-VEGF, I'll give it at the end of the surgery.
Fantastic.
Intravitreal.
And just to conclude the whole thing, discussion about submacular hemorrhages, very large, massive submacular hemorrhages, as Sangeet showed in one of the cases, if there is a old one with lot of dehemoglobinurized blood, nowadays we are combining it with an autologous RP choroid transplant, along with removal of the hemorrhage. Me and Shubhendu both are advocates of that technique. Now, I think we have come almost at the end. Because we have already asked Aditya during his presentations whatever to be asked, and Ramandeep also.
One thing
Any
about
of you have questions
for your talk, the ab externo removal of subretinal bands. It looks very nice, very easy when we see it. But very few people are doing it, and they're very expert in doing this technique. One thing is like the location of the band is very important when you're going to remove it, because you're making a sclerotomy, another sclerotomy, posterior sclerotomy, and sometimes it's very difficult to reach that band through that sclerotomy until and unless your location is very good. Second issues that I have had when I try to use it is like if I use a non-valved cannula, through which I enter, what happens is the fluid leaks out, the space decreases, and your entry of the instruments becomes very difficult.
Fantastic.
And if you use a valved cannula, the problem occurs is when you trying to pull out the band through the cannula, it gets stuck over there. It does not come out easily. So you have to remove the cannula, and then you have to remove the band. So these things.
Absolutely, because I agree with those 2 points. Plus, I have a reservation in situations where, as I mentioned, extensive PVR, multiple very large extensive areas of subretinal bands. So it's to go on, people I have seen madly putting cannulas in all possible quadrants, in 1 quadrant, 2, 3. So that is madness. It's better to do an extensive thorough retinectomy, seed, as I showed in the videos, direct, very meticulous cleaning of the bands, and then resettling the retina once again. Brilliant points made, Sangeet. I think that's the end of the discussion. And I would like to thank the audience for coming and gracing the occasion, and to all my co-instructors for making it possible. Thank you. Let's join for a group photograph here.